We can have custom testing, historical comparison with the Humphrey, and progression for size 3 as well as size 5 tests. So we can have a significant number of permutations that are possible. Now, the test patterns that are available, we have already seen on the Octopus. And for glaucoma, essentially, we use the G pattern and the M pattern because they are the prototype patterns of the Octopus with slight differences from the Humphrey. Although we have the luxury of the 32 pattern from the yesteryears, we have the luxury of 30-2, 24-2, and 10-2 from the Humphrey as well. So if you are comfortable with those patterns, please go ahead with those patterns. We can do tests on those patterns as well. So the G and the M are the basic, and 24-2, 10-2 test patterns, and 30-2 are the add-ons. Except the 24-2C, which is the new addition to Humphrey, all the other test patterns are available. Now, the test strategies. Now, strategies have already been discussed. These strategies are with a slightly different name, but basically convey the same ethos as they are there on the Humphrey. We have the dynamic, which is comparable to the CETA. We have the low vision, which is that option is not there on the Humphrey. We have the top, which is like the CETA fast. We have top faster, which is like the CETA faster, and normal, which is like the normal strategy or the full threshold strategy of the Humphrey. So we have all the strategies available. Testing times are absolutely similar. The foveal thresholding time, although is not there in the Octopus because the fovea is not tested separately as it is done with Humphrey, because we have a central area of the fixation target which is open, unlike the Humphrey, which is a LED diode. And so you have the entire spectrum which you can use in this machine, like G dynamic, G normal, G top, M dynamic, M normal, M top, 24-2 dynamic, 24-2 normal, 24-2 top, same with the 30 degrees, 10 degrees, and M. So M dynamic low vision is a different strategy which is available to the Octopus, not available in the Humphrey. And we can have a 10-2 dynamic low vision size 5 also. So we have all types of permutations and combinations, and normative data is available for all these tests. Now, stimulus size settings, we basically always use the size 3 white on white. As we all know, it is the clinical standard. In the low vision, we have the white on white stimulus size 5, which is used for advanced field loss. Gaze control and fixation targets, we have adjustable. These fixation targets are slightly different from that in the Humphrey, which is a central LED diode or large diamond, small diamond. Here we have 4 LED lights in the central, that is the central target, and then we have a central dot, which is not used for glaucoma testing, in the central area. And we have a ring. Ring is used for low vision patients with advanced loss splitting fixation, because they can't see the central target well, and patients with central scotomas. Gaze control, we don't have the Heil-Krakow method of blind spot monitoring. Here we have a direct superior video control or a video monitoring and a contact control. The contact loss to the forehead and the chin, the machine freezes. Similarly, if there is motility outside the grid that you can see in the photograph here, if the eyeball moves out of the grid, the machine freezes. There is no stimulus that is introduced. So there is no question of patient, no indirect way of monitoring fixation. It is a direct way. Patient loses fixation, the machine stops. It is commercially called as in 4 levels: none, minimum, medium, and automated eye tracking. In the automated eye tracking, the patient face is again recentered to come in the center of the lens, but we usually do not use that because it is not required. Patients do well with the medium control, that is the blink, dart, and pupil position control, exceedingly well. Now, G pattern is one pattern that we need to talk about, which because it is specific to Octopus. The 24-2C of the Humphrey that has adjusted this to this previous advantage of the Octopus, where you have additional testing points in the central grid, or the central 10 to 12 degrees. And apart from that, the difference being that the blind spot has lesser points, because usually we do not find significant information just near the blind spot except the bearing. Apart from that, the distance and the area of the pattern is pretty different as compared to that in the 30-2. So the points are around 59 in the G pattern, and they are oriented around the retinal nerve fiber layer alignment. Options that are available for field test area are 74 test location of 30-, the 30-2, the 32, and the 24-2. So whatever you want to choose, you can choose. If you are not wanting additional data in the center as is available with the G program, you might as well go ahead being comfortable with the previous 3 programs for which normative data is also available. Now, scotomas in the central part will definitely appear different in the G program because of the denser grid as compared to the 24-2. So the similar patient on the right side on the Humphrey and left side on the Octopus, you can see the data appears slightly different, and you can get a curvilinear scotoma here, whereas it appears like a straight line or 2 points adjacent to each other in the 24-2. So these differences will be there when you transition from one machine to another. Strategy, the dynamic strategy is similar in all respects to the CETA standard strategy. And if you can see here on the right hand side, the examination pattern is given. It is the G, the dynamic, the auto white on white perimetry. Satyan sir, I'm continuing, right? For the, yeah. So, and here you get all the dimensions like the pupillary, pupillary diameter, the false positive, false negatives, testing time, and the type of fixation monitoring that is used. So all the information that is there, what you see in the Humphrey above is given here, similar fashion, including the pupillary diameter, and the only additional thing is the automated eye tracking, which is slightly different. Now, what you can do here specifically is you can customize the printout. Now, in the printout, if you want here that you want a cluster analysis, you can have one. If you want a corrected cluster, you can have one. If you want a values map, you can have here. So you can just keep on flipping and changing the pattern as you are comfortable in that particular situation. The main difference here is in the total deviation numerical plot. If the deviation is not more than 6 decibels, it is not marked in values but just a plus sign, which decreases the clutter on the map. If there is a complete scotoma or a full scotoma, then it is like a black dot. There is no value which is given. So these are the slight differences in representation which are there and which are very, very convenient to use while testing. Now, if you do a 24-2 test, then also the same kind of printout is available to us, and you can have continuity of the 24-2 test from the previous Humphrey's historical data. And you can see here a beautiful progression map is obtained, and you can have these two last symbols are different, which indicate Octopus machine vis-a-vis the Humphrey machine, which is indicated as a cross, and you can get a progression map even on previous Humphrey data. Now, the M program, which is specific to Octopus, is also slightly different. The targets are oriented just 1 degree apart in the center with a dense central grid and then the radial points. You have 81 test locations vis-a-vis the 76 test locations of the Humphrey, where the central grid is relatively sparse. And again, you have options of using both the programs. So if you have a historical 10-2, you can use a 10-2. If you don't have a historical 10-2, you can start with the M program. The choice is yours. Now, here you can see we've used the size 5 stimulus and a low vision strategy, low vision dynamic strategy in the M program. That is a magnification of the central grid. The test pattern is the same as that of the M program, but the stimulus is size 5. The advantage is it crosses the threshold only once, and it starts with the brightest stimulus. That prevents fatigue from the patient of not seeing the stimulus for a long time, especially in cases of advanced visual loss. Now, the increase in the dynamic range of the machine can be obtained by using the size 5. Now, you can see here the central, the patients having only central vision can be magnified using the M program. Now, you here see a prototype example here, a G dynamic program showing a loss threatening fixation. You make a M dynamic size 3, you can get slightly more information, but when you make a M dynamic size 5, then you get more and more area that you can interpret and follow. On the left side, you have the progression printout of M dynamic size 5, which is usually not available in most machines. Now here again, increasing the dynamic range from a M size 3 to a M size 5, and then following up the size 5 on the progression printout. Because it's a paired t-test, you don't have to have historical data which is acquired over 15 days from a pool of glaucoma stable patients. This just compares the patient to his historical previous data. So the interpretation workflow in Octopus is slightly different. Here we have some similar things like patient detail and the reliability indices, but then you have the defect curve, which is different. The probability map is same as the pattern deviation maps on the Humphrey. We have a grayscale and comparisons, that is the total deviation numerical plot and the grayscale. Grayscale in the Humphrey again is different from the Octopus. In the Humphrey it is absolute. In the Octopus it is relative because it compares it to the normative database. You can have cluster analysis, which clusters the points into groups, which the mean of which is denoted in the cluster analysis. You have a polar analysis, which detects the structure function correlation. We'll see it in very short in the next few slides. So here we have the maps, the values map. If you want, you can incorporate in the printout. Otherwise, this is the grayscale comparisons, the defect curve, which has already been described. Sir, tell me when the time is up. I'm not able to understand. He's clicking the previous session or the next next one.
Yeah, I am sending the message. It is not reading the message. So let him see the message. You please continue.
Okay. So here you have what is called as the defect curve or the Babius curve. The usage of the curve has already been described by Dr. Murli in his previous slide. And then you can, as I said, you can customize here. In early defects, I customize this to corrected cluster analysis, whereas in the later stage, when the defect becomes more diffuse, I just convert it to cluster analysis so I can get a clear image. And polar analysis will be the field test data result, which is flipped across the horizontal midline. And then you can get each point being represented as a line. The longer the line, the deeper is the defect. So here is the thing that you can see in detail, which I was just talking about. You can customize the grayscale into comparisons and corrected comparisons grayscale, unlike the absolute scale of the Humphrey. Clustering and averaging in the cluster map reduces the influence of normal fluctuation on individual points. 10 clusters are there, and the average of each cluster is denoted. If the value is normal, it is denoted as plus, as is the representation across the octopus perimeter. And if there is a deviation into significant percentile values, and it is denoted in orange and red color with values in bold. This is the polar analysis. Here the FOV values in the left on these maps, comparisons maps are flipped, and then they are denoted as lines originating from the optic disc, and they will usually compare to the quadrants in which the loss is there. So the longer the lines in the quadrant indicates that particular quadrant is pathological on the optic disc. So you have to see directly the optic disc in that particular way, not flip it anymore, because it has already been flipped while making the polar analysis. As far as the reliability of the global indices go, we have 5 indices with us. We have the MD, the SLV, the DD, the LD, and the MS. The DD and the LD are derived essentially from the defect curve using the 12th to 16th and the 14th to 59th rank of the defect curve, the average of which is given as a diffuse defect or local defect. Insensitivity has already been described. And the glaucoma cluster test is basically the hemifield test principle applied to the glaucoma cluster data. As you know, in hemifield, the nasal, the temporal data, temporal to the optic disc is not being used. Here we use the entire data across the spectrum and then compare. The results are similar to that given on the glaucoma hemifield test. There is a recently added system, that is the Brucini stages in system 2, which divides the field into 6 stages and 3 types using the mean deviation and the pattern standard deviation values. Now, due to paucity of time, I'm not discussing that in detail, but all these can be given as a comprehensive global indices section in the octopus perimeter.
Thank you, Sachin.
Yeah,
thank you so much for covering. In spite of I was just given you a very short notice in the morning. Thank you so much for covering both the talks. Unfortunately, we couldn't get the event today for some emergency.